Alright, just 2 slides in this next video, and we're going to talk a little bit about frustration and aggression. In the pretest, I asked you to consider whether or not dealing with frustration as a result of interacting with authority figures was a natural response. Hopefully you answered that it wasn't. I'd like us to keep in mind that in many cases we would go to authority figures to help us navigate through stressful circumstances. In other words, we're hoping that they're going to help us to reduce or avoid frustration. But when we go and see those authority figures and instead end up being kind of obstructed, our frustration levels tend to increase dramatically. The other thing I wanted to ask you to think about is whether or not frustration is automatically connected to anger and aggression. And the research shows that in fact it is not. Many people are able to get frustrated and move directly into a resolving type of behavior, while others are withdrawers, which isn't necessarily a healthy thing to be, but at least it's not aggressive. So frustration and aggression are often things we will see as first responders dealing with some mental health consumers in crisis, but they aren't inevitable, and in fact there are many reasons why a person might move from frustration into aggression. So frustration is linked to anger and aggression in places like emergency wards and in other interactions with first responders. It's especially common when the patient's experiencing any of the following things. First, any perceived need or threat. So if the individual feels as though they may not get their need met, or that they are in danger of having something done to them or losing something of value to them, we can expect them to move into a defensive mode. Pain or illness, and I'm talking predominantly here about physical illness, also overlay a person's feelings of frustration and anger, and we often lose some of the things that slow us down or filter us from becoming aggressive. Feelings of inadequacy. And even if we don't enter the situation feeling inadequate or disempowered, when we often walk into systems that are often large systems, bureaucratic systems, or hard to understand systems, we may feel very inadequate indeed. I think of myself as a pretty informed and educated guy, but when I go into a psychiatric facility and I don't know my way around, right off the very beginning, I feel inadequate. And that's just one of the simple ways that we're communicating to people that they may not be in a comfortable, powerful place for themselves. So I know, for example, that when a facility is being developed, we want to really improve things like signage and sight lines and have the places where staff are congregating be easily accessed. If you're going and tucking yourself away in a corner office, then chances are you're going to aggravate this feeling of inadequacy for other people. Anytime a feeling that expectations are not being met is very difficult. And you know, it's funny because this sounds like a really obvious thing, but perhaps the most obvious part of it is that we don't ask people what their expectations are, and we don't ask it of them when they're calm. So it would be very useful for us to have a chance to discuss with people about their expectations and give them a sense of what's realistic in a given venue and a given program before they build up frustration based on the fact that their expectations were never realistic in the first place. Anxiety, both pre-existing and anxiety that mounts as a person, for example, is exposed to things like machinery, needles, or uniforms. All of those things, for some people, can cause a growing anxiety. Pre-existing frustration, the person might have had previous experiences that were very negative in this setting, or they might simply have come to that environment having had a very bad day. Chances are, if a person's in your facility and they're going through crisis, they've had a process that led them there. And so it's important for us to go back to that rational detachment we talked about earlier, understanding it's not all about us, and it's probably not all about the interaction we're having at that exact moment. Any obstacle that blocks a goal or is perceived to block a goal is going to cause frustration for a person. If you're perceived to be that obstacle, you can see that they're going to be an attempt in many cases to move you in terms of either physical aggression or things like threatening behavior or reporting behavior. And by reporting behavior, we mean that a person tells on you, essentially. Any anger displayed by others can be seen and should be thought of as essentially contagious. Often it's very shall we say, empowering for one individual who's been keeping themselves kind of calm. They see another individual lose their cool, it sort of offers them permission to do the same thing, and it can run sort of as a stampede effect through a small crowd. So it's important for us to try and help people universally maintain their emotional state. And any aggression displayed by others does a very similar thing. It only aggravates things further. Perception is absolutely everything, and I can't emphasize this enough. It doesn't really matter whether or not you think that you're not being an obstacle. It doesn't really matter whether you think that you're disempowering a person. It's important to constantly be aware of that other person's perceptions. And when they're telling you this is taking too long, or when they're telling you people don't care about me, it's the easiest thing in the world to explain why it hasn't taken that long. Do something like, well, it's only been 20 minutes, or to argue that you actually are doing the best that you can. But when we do that, it invariably backfires. If you think about it, how many times have you seen those type of responses being useful for people? Almost invariably, they work the opposite to the way we intended them. Instead, it's important for us to try and understand where that person's perceptions are coming from, and asking questions is often far more effective than telling people answers. For example, a question I might ask is, how can I help you with this? Or, I know it's going to be a little bit longer than it has been so far, and I understand that's very frustrating. How can I help you to wait? So our reality and that of the consumer are always going to differ. And the interesting thing is that we often become as frustrated with them as they with us because of our perceptions, and they're probably not feeling our perceptions are any more accurate than theirs are about us. By the way, this came from that same emergency mental health education manual I referenced earlier, and it's one of the many things, again, that you can get from that manual. Voluntary and involuntary admissions are something we want to take a moment to talk about. After this video, there's going to be an optional section, which is predominantly for those of you who are working emergency first response, especially police officers or anybody who has to engage the police. And that section is going to deal with the legislation, sections 22 and 28, and clarify exactly under what circumstances police can transport people to an emergency medical facility and under what circumstances a doctor can admit an individual. But even for the people who chose not to go into that optional content, I did want to spend a moment talking about this. The first thing I want you to understand is that not every hospital is a psychiatric unit. Not every hospital is a designated facility where a person can be treated or observed for mental health conditions. Mission Memorial Hospital is not a designated psychiatric unit. The closest ones we have, Abbotsford Regional Hospital and Ridge Meadows Hospital. So if a person goes to Mission Memorial Hospital with a apparent psychiatric condition, there's only really two options. Option number one is that the person is not going to be admitted in any way. They voluntarily discharge. Or option number two is that the person is transferred either under their own choice, under their own power, or through a transfer ambulance, or through somebody like the RCMP over to Abbotsford Regional Hospital or Ridge Meadows Hospital. And that's not because the people in the hospital don't want to help. It's not because the people in the hospital have some prejudice against people with mental illness. It is literally because they're not empowered to help beyond that capacity. Now, when we talk about voluntary and involuntary commitments or admissions, it's important for us to understand that voluntary admission is always the easiest and most powerful for the very reasons we just spoke of. Once we do something against a person's will, we automatically mount the frustration. And with that, we make it far harder for us to provide service to that individual because they're going to be hostile and they're going to be defending every step of the way. So if you notice that a clinician, like for example an emergency room doctor, seems reluctant to admit somebody against their own will, this is why. From a clinical perspective, it's incredibly important for that person to be there as much as possible under their own conditions. We cannot force change, and people have the right to constantly demand to be released or to fight against particular interventions. So it may seem on the surface like the simplest thing to do is to admit a person, but if the doctor knows that at every step of the way that individual is going to fight to be released from the hospital or not to receive the service, and they also know that there's a room full of people waiting to get that bed who would be happy to be there, you can see why they are not going to be quickly willing to do this involuntary admission in most cases. So they're going to try giving time and spending a little bit of energy building relationships in most cases to encourage a voluntary admission, or to have the social worker or other staff or even the family investigate whether there's a community-based alternative. I know that as lay people, we often come in and think this person needs to be in the hospital, but that's often sort of the equivalent of hitting a fly with a sledgehammer. We can do some of the things, for example, suicide watch or observation of a person, adjust medications, or provide services that are therapeutic without having a person staying in the hospital all of the time. So they may be able to receive those services in a community-based facility or come into the hospital on an outpatient basis. It's best to work with the consumer and the family to encourage voluntary access to care. And when families come to the hospital and say they want their child admitted because he's suicidal, this can be a real challenge. But we need to be understanding of that family's needs without necessarily automatically assuming that there's only one option. So is there a way to provide for the safety and security of that child without automatically admitting that individual right away? Now, I cannot go back and forget something, or can't go back against something I said earlier, which is that we also need to significantly trust families. So working through this conversation is not all about getting your way. It's important that it's a two-way communication and that we truly are listening to what families are saying. So we need to have a list of approaches. And what I'd like you to do right now is take some time in your journal and write down some of the things that you've noticed are effective ways to get a person to be more likely to respond to you. What are ways that you build cooperation, if you can think about it in those terms? All right, so put those on the journal, and the next video will be an optional content video. If you want to skip it, you can. The content will be all about sections 22 and 28 and the specific criteria that doctors and RCMP officers use before they accept an individual as an emotionally disturbed person, or EDP.